I would like to welcome everyone to today's webinar, A Culture of Safety is a Culture of Compassion. I'm Andrea Greenberg, Communications and Partnerships Associate at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin this formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listen-only mode, but can interact with the speakers by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the presentation. We will be polling the audience during today's session, and we hope that you will participate in this interactive measurement tool. Finally, as you exit the webinar, you will receive an electronic survey that we ask you take a minute to complete so that we may capture your assessment of today's program. Your feedback is really important to us. And now, it is my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Andrea. Good afternoon, and thank you, all of you out there, for joining us for our 2017 webinar series on compassionate collaborative care, or what we're calling the CCC. The Compassionate Collaborative Care Framework describes some of the key values and behaviors that help us offer compassionate collaborative care to patients, families, colleagues, and coworkers while also sustaining ourselves and our sense of meaning in our work. This framework is available on our website. This year, the Schwartz Center webinar series is focusing on creating organizational cultures of compassion and collaboration. This is also the focus of our inaugural annual Compassion in Action Healthcare Conference in Boston this June 25th through 27th, 2017. We have a fantastic lineup of dynamic and innovative speakers for this event, so please visit our website and be sure to register to attend. So now let me introduce today's session, A Culture of Safety is a Culture of Compassion. At the heart of healthcare is our purpose and moral duty to provide the highest quality, safest, and most compassionate care to all of our patients, families, and colleagues. Yet so often, our best intentions to ensure compassionate care are thwarted by many, many reasons, some pernicious, some explicit, but most of which relate to macro and micro systems that lack a full commitment to a culture of safety as not only our priority, but also our purpose. During today's presentation, Patricia McGaffigan will illuminate several of the root causes and challenges to creating and sustaining a culture of safety, as well as the importance of a total systems approach to safety that is truly preconditional for compassionate care. This session will provide you with meaningful recommendations and resources to accelerate and sustain a culture of compassion and optimize compassionate care. By the end of this presentation, participants will be able to characterize the relationship between a culture of safety, patient workforce safety, and compassionate care, identify at least 3 detractors and 3 critical success factors that relate to a culture of safety, and to apply at least one essential recommendation to their patient safety and workforce safety activities or programs that may optimize compassionate care in their organization. Today, we are honored to have as our speaker Patricia McGaffigan, Chief Operating Officer and Senior Vice President of Program Strategy at the National Patient Safety Foundation. Welcome, Patricia. I'll now turn the program over to you.
Thank you for that introduction, Dr. Lown, and for the honor to be speaking to all of you today as an important part of this Compassion in Action webinar series. As Dr. Lown noted, it's my goal that you leave this session today with a better sense of understanding of the relationship between the culture of safety and a culture of compassion. Before I speak about the linkage
I'm sorry, I think our speaker is muted at the moment. Patricia, can you check on that?
Hello, this is Patricia, and I will start over. I apologize. I want to say hello to all of you and thank you, Dr. Lown, for your introduction. It's my hope that you leave here today with a better sense of the connectedness of the relationship between cultures of safety and cultures of compassion. Before I speak about the linkages of safety, I'll ask our team to move on to the next slide to share a bit about our organization. Now in our 20th year of operation, and we'll move on to slide 7 as we've covered these objectives. The National Patient Safety Foundation's vision is a world where patients and those who care for them are free from harm. Our mission is to partner with patients, families, and those who care for them, and to ensure that we're delivering meaningful strategies and resources to prevent harm across the entire care continuum. Our 3 goals, as you can see, are to advance patient safety as a public health issue. And last week, we released a call to action on the critical need to do so, which you may find on our website. Our second goal is to establish patient and workforce safety as a core value of all leaders and organizations. And finally, we focus on building workforce capacity to ensure that our colleagues in healthcare are skilled and capable in safety science. On this next slide, you'll note our summary of the way we do our work. It's actually much like the Schwartz Center and mirrors, in many cases, how your organizations may work. In the interest of time, I'll just let you take a glimpse at this, and if you have any additional questions, we can discuss those later. But let's jump into the heart of the matter, the relationship between compassionate care and a culture of safety. Stories are often used along with evidence, as you know, to advance changes in healthcare. And I wanted to begin with a story that's actually about me. Once upon a time, in fact, only a few weeks ago, I had to be seen in the emergency department of a large teaching hospital. And the reasons why I needed to be seen don't really matter as much as what I saw and as much as what I experienced. I actually felt quite helpless, as you'll note on the next slide. Most emergency departments, the entire department was hopping, and for about 9 hours I was on a stretcher in the hallway right next to the nurse's station, and I happened to be right under multiple electronic health record stations, right under the printer, and with direct line of sight to the emergency department whiteboard. It was probably the best bed in the house to observe what was happening in the ED, but the worst bed in the ED to actually be in. I knew I was far from the sickest patient in the ED. I was on the other side of the bed, however. I wasn't a nurse. I wasn't a family member, as I've too often been in the last several years. I was the patient. And then things suddenly changed, as they have for all of you. We become not the business person or the parent or the spouse that we are. Only an hour prior, I had been reduced to being part of a system where my autonomy had suddenly been stripped. And while I felt helpless, there were actually, as you can see on this slide, 2 options to request help right next to me. On the far right of the slide, there was a red sign saying that I could push for help. And the only problem was there was no help button below the arrow. No problem, I thought. I had another option about 18 inches to the left where I could pull for help. And while I boiled this down to a technical change that at some time had taken place in the emergency department, the message to me was so very meaningful. If I wanted to or needed help, this emergency department had not been able to find the time or relate to the very mixed message that this setup was actually sending. As we move on to the next slide and pull up a couple of photos here, I'd like to share with you a few perspectives that I had. Well, I was worried about myself. The prime location that I actually had at the nurse's station caused me even more concern because I became worried for patients and family members. Some were in hallway beds like me with unclear bed numbers. One hallway bed that was supposed to be mine, but I saw across the aisle was with the same number. However, that number had been crossed out and another number was substituted in pen. I was worried for the patients who were alone, for the patient who did not speak English and who was clearly in pain and suffering and couldn't begin to share their own story of why they were here because they were waiting for a translator. I was worried for patients who had no privacy. I was fully privy to conversations with and about at least 6 other patients who were in the hallway or in nearby beds. I experienced and watched numerous exchanges of healthcare providers and patients that didn't start with introductions, nor were roles explained. And in nearly all cases, those patients who did have family members with them, even some who were quite elderly and had absolutely nowhere to sit with their family members, looked lost. Their only choice would have been to have gone out into the waiting room, creating the ultimate disconnect between what patients and families want and need when they are receiving care and most need to feel a connection. I was also, and very sincerely, worried for the healthcare team, something that in my personal encounters with our healthcare system, I have spent far less time thinking about, despite my passion for understanding the challenges and needs of our workforce. During the abundant time I had to wait and watch, I actually felt more anxiety about the healthcare professionals in the emergency than I did for myself, for several reasons. They were swamped. They went into code purple. Their emergency department was over capacity. There were literally 3 early warning alerts in 3 adjoining rooms within minutes of one another. I was worried for the physician who literally ran by my bed while shouting out the results of an imaging test to someone, and I later realized it was mine. I was worried about teams that were struggling to connect with their other team members, waiting for time and access to their peers and specialists. I was worried for those who were telling stories that I could very clearly hear at the nurse's station about being at the lowest end of the pecking order. I was watching them eat unhealthy food, if anything, and clearly overloading on caffeine. And I also was very worried for the nurse who asked me to sign my discharge instructions without telling me what they were or what was even found during my now 9 hours in the emergency department. And I know that's not the way that they want to give care. On the next slide, you'll see an image of the Dalai Lama, which causes me to sit back and reflect, was my care actually safe? And from a technical basis, I'd give it an okay. However, as I mentioned, I knew that intellectually and clinically, I was nowhere near as ill in the same sense of so many other patients who were in the ED for that 9-hour period, and some who never made it out of the emergency department to a hospital or to their home. Do I believe that my care was compassionate? Well, on that front, I'm not so sure. And I don't intend to suggest that I have no appreciation for having access to some of the best healthcare facilities in the world. I have no intention to come across in a pejorative manner or to reflect badly on my care team with what I fundamentally knew had very rich and outstanding skills. But if we think about the Maslow hierarchy of needs approach, we know that our foundational needs are physiological, followed by a sense of safety and security. And safety and security can mean many things. It's often referred to in the description of the hierarchy of Maslow as freedom from harm and danger. The Dalai Lama also reminds us to at least not hurt others. However, he also says that love and compassion are necessities and not luxuries, and without them, humanity cannot survive. And in so much of healthcare today, and especially in fast-paced environments such as in ED, we're challenged and struggling to ensure that care is physically and technically safe. However, as patients and families, our humanity is essential, and each of us want and need to be treated as equals, as assets, and as valued, regardless of which side of the bed we were on. So as we move on into our next session and our next slide on safety, let's step back for a minute and ask you a question about where you think safety is considered, where you think it stands in your own organization. I'll hand things over to Andrea for our first polling question.
Great, thank you very much, Patricia. Our first polling question should be appearing on your screen and reads, "My organization states and embodies a full commitment to zero harm to patients and the workforce. Please select one of the following responses that best reflects your opinion. Yes for both our patients and our workforce, yes for patients only, neither, unsure, or not applicable." All right, so send in your answers, and we will share the results in just a moment. Okay, we have a good response. So let's close the poll and share the responses. Let's see. So 73% said yes for both our patients and our workforce. 14% said yes for patients only. 8% said neither. 4% said unsure, and 1% said not applicable. Patricia, any thoughts on these results before we jump back into the presentation?
Actually, Andrea, I think these results are absolutely fabulous. And I know that many people who join webinars such as the webinar today may come from organizations that are actually much more advanced in their consideration of a full commitment to zero harm to patients in the workforce. I think this is probably an overestimate of what we might see in general and what we typically hear from the many individuals around the world who we interact with. So let's go back into the presentation now and talk a little bit more about a report that we issued that was intended to examine the state of patient safety 15 years after the creation of the Institute of Medicine's report, To Err is Human, Creating a Safer Healthcare System. I'd like to let you know that this report is available on our website. We convened a panel that included a range of disciplines, including some of the original authors of the Institute of Medicine's report. In this discussion about whether or not care was actually any more safe, you can see on the photo here the faces of several individuals who were considered experts, two of whom sat on the original report, Dr. Lucian Leib and Dr. Don Berwick. And you can see their faces. This was actually a photo that was taken at a time when we were asking ourselves whether or not care was in fact any safer. And the panel concurred that their findings were actually mixed, particularly around whether or not progress truly had been made. There was agreement that we had made progress, substantial progress in certain areas. However, that we had not made enough overall progress. The progress we had made was often driven by sticks, and there was much more work to be done. And the panel discussed the related complexities of this work for very important reasons. In fact, reports of error and harm to patients continue to grow, with death from preventable medical error now estimated to be one of the top causes of death in the United States. Our panel also discussed harm to the workforce. And as many of you are aware, our colleagues in healthcare are working in an industry that actually experiences far more physical harm than industries such as mining and manufacturing. If you're an emergency department nurse in the location where I was, for example, you're 5 to 6 times more likely to be a victim of physical assault than a taxi driver. Rates of turnover, burnout, depression, and suicide are at an all-time high across our entire healthcare workforce, and this also includes executives. And because the vast majority of errors are not actually due to things that people want to cause to go wrong, but are a result of systems error, it's important to keep in mind that we probably have a very, very important large issue to tackle, and that is what our panel concluded as part of the work as they tried to understand the true root causes of why our care is not yet safe. Our panel concluded that it was time for an overarching shift to move beyond the more reactive and piecemeal interventional approach that we have been taking, and encouraged us to strive to move away from addressing circumscribed initiatives to what we really believe is most foundational and necessary in order to create cultures of safety, where there's full organizational attention to safety and where initiatives are more likely to be sustainable and successful. And as we look at our world today, we can talk a lot about the reactive piecemeal approach. This has really actually been something that's been both good and both somewhat challenging. We've taken certain challenges like bloodstream or catheter-related infections, and we've made incredibly marked progress in these areas. We've done this by addressing circumscribed issues, and there's no doubt that this progress is absolutely critical. However, in general, we can also say that we have a healthcare environment that's been incentivized to focus on some of these easier to do and quick wins. And we check the list and we believe they're done. And we keep checking the list. We're doing a lot of doing, and we're actually getting very good but very tired of doing, as you can see on the left side of this slide. On the right side of this slide, it's really a representation of being. And over this past weekend, I read a book that some of you may have read by Dr. Jessica Zitter called Extreme Measures. Dr. Zitter holds one of the more rare combinations of board certification in both pulmonology and critical care and palliative care. And by the way, this book actually makes mention of the wonderful work of the Schwartz Center. Dr. Zitter notes that she had no idea and wasn't prepared for the full scope of human suffering that she would see as a physician. She talks about critical care, surgery, and cardiology as some of the doing specialties where physicians were seen to be heroes. She talks about we have innumerable protocols for doing things to patients and almost none for undoing things to them. She states that she went into medical school as a human being and came out as a doctor. She compares the common practice of substituted judgment, where decisions are made by healthcare professionals for patients, as compared to shared decision-making, where the importance of the being of the patient, the connection with the patient, is so vital. And she notes in her transformation to palliative care that there is even time in the busiest of environments to bring attention to the human elements of care. And if we do not do this, patients simply become bodies that we are, under most circumstances, trying to keep moving on a conveyor line of life. But this more foundational part of moving from doing to the essence of being is so much harder to do in the absence of cultures of safety. And so our panel made recommendations that we should be taking a total systems approach to safety. We should be focusing on the prioritization of safety culture by leadership, examining it across the entire care continuum, addressing the well-being of safety in the workforce, and avoiding adding disjointed initiatives to a stress delivery system and workforce. This transformation from how we've been approaching safety in those reactive piecemeal circumstances in many cases to how we must be approaching safety is nicely exemplified in this slide and in the next using the framework of Dr. Eric Hollnagel, who is a leading expert on industrial safety. Let's say that our traditional approach to safety in healthcare has been more of the Safety 1 construct on the left, and where we want to get to is represented by the Safety 2 construct on the right. In Safety 1, the definition of safety is that as few things as possible go wrong. Well, in Safety 2, the definition on safety is ensuring that as many things as possible go right. Safety 1 is more reactive and is often linked to an occurrence of harm, versus Safety 2, where we have a more proactive and anticipatory mindfulness that allows us to anticipate events and prevent harm in the first place. As we try to understand how an accident or adverse event happens in the Safety 1 construct, in Safety 2, the focus is more on understanding what goes right as a basis for explaining how occasionally things go wrong. And to conclude on the framework, let's look at the human factors. In Safety 1, humans are often seen as liabilities or hazards, where in the construct of Safety 2, humans are viewed as a necessary resource to build and sustain systems that are flexible and resilient. And finally, in Safety 1, performance variability is harmful, often because in healthcare, this performance variability is actually negative deviation from standard practice, and it can contribute to greater risk and harm. As compared to Safety 2, where minimizing variability is important, however, on occasions, positive deviation may actually be useful. So what we've really been referring to for much of this Safety 1 versus Safety 2 discussion is fundamentally about culture. And culture, for our expert panel, became the primary area of focus and designated improvement if we are to meaningfully improve care. And in reality, as we take a look at our approach to circumscribed initiatives of safety, they are not necessarily sustainable or successful because the foundation for safe care, a culture of safety, may not really be present. So let's move on to culture, and I'd like to spend a few moments digging into this angle a bit more to help us build this connection between safety, culture, and compassion. And once again, I'd like to kick this off with a reflection of how you think about culture and compassion in relation to your organizations. And I'll turn things over to Andrea for our polling question.
Great, thank you very much, Patricia. Our second polling question should be appearing on your screen and reads, my organization considers safety and compassion as our purpose. Please select one of the following responses that best reflects your opinion. Absolutely, mostly, sometimes, poorly, or not applicable. All right. As questions come in, as the answers come in, we will share these in just a moment. Okay, we have a good response, so let's go ahead and close the poll and share the responses. All right, let's see. It appears that 46% said absolutely, 40% said mostly, 9% said sometimes, 4% said poorly, and 1% said not applicable. Patricia, do you have any thoughts on these results before we jump back into the presentation?
Thanks, Andrea. I actually do. And once again, I would compare those to some of my comments on the first polling question. We've got a great audience of individuals and organizations that are represented here today that clearly are making safety and compassion a key purpose, their purpose for existence and for why they come to work and provide care every day. And I would estimate and guess based on some of the other polls that we've done with other audiences that these numbers are probably higher in general, probably due again to some of the positive bias of the folks that are on this webinar. We still do, however, have some work to do. More than 50% of people cannot say absolutely. And I think in an ideal world, that is where we'd want to be. So let's move back into the presentation itself and talk about culture. In the Free from Harm report that I introduced earlier in our conversation, there are actually 8 recommendations that encompass many areas, including the patient and family. The most vital recommendation, however, from our expert panel was to ensure that anything that could be done that could ensure that leaders would establish and sustain a culture of safety was most critical. They clarified that improved culture isn't a means to an end. We don't do culture as a checklist or something, that we say, okay, we finally got it. We often treat cultures of safety as one of many safety activities. And in many cases, we often say that we have a culture of safety because we've reduced infections. Or we'll get to that once we fix this other challenge. And one of my personal perspectives is that we ask leaders to actually prioritize safety amongst their many other priorities. And this prioritization is really important because it keeps safety at the forefront. However, I think many of us on this webinar might argue that isn't safety much more than a priority? And do we have to ask whether it is a priority, especially if we believe that it is our purpose and our duty to ensure that care is safe? Now, there are many articles and bodies of work out there that talk about the importance of a culture of safety and the relationship of strong cultures of safety to reduction in harm and error, improving patient outcomes, experience, and satisfaction, improving workforce safety, satisfaction, and engagement, which is really important because this is where the connectedness needs to come from, reducing cost and waste, improved and more transparent care and more trusted business, and more compassionate care for patients and for our workforce. Well, what's standing in the way of getting to these cultures of safety? One of the most clear challenges we have faced and continue to face in healthcare has been so aptly stated by Dr. Lucian Leap, the former chair and continued member of our Lucian Leap Institute. The single greatest impediment to error prevention in healthcare, he says, is that we continue to punish people for making mistakes. And this fear of punitive action is actually very real. It's more of a norm, and it's emblematic of our profession. The Agency for Healthcare Quality and Research provides surveys that are routinely used by many healthcare delivery settings, such as hospitals, offices, and nursing care centers. And many of you have probably seen and worked with your results. However, consistently, the most poorly rated item in the database of patient surveys across hundreds of thousands of healthcare professionals and hundreds of hospitals is this issue of non-punitive response to error. On average, in this most recent 2016 comparative user database for hospitals, only 45% of respondents felt that their mistakes will not be held against them, and they will not be held in their personnel file. So instead of actually having a culture of safety where individuals are comfortable about speaking up, about reporting errors, about reporting risk, about admitting things that go wrong, we have organizations that are actually shutting down the critical voice that is much needed to evolve safety. So let's get back to this concept of freedom from harm that we talked about earlier and examine two important issues. These are the issues that detract from our having authentic and foundational cultures of safety, the critical detractors and the critical success factors. The reason why it's so important to understand these factors, and I know many of you already do, is because each of you are aiming for and leading connected, compassionate care as a purpose, which is clear from our polling. And it's vital to level set ourselves on at least some of the reasons why this is actually so hard to do. So here are some reasons, some critical detractors for why cultures of safety don't exist. As I mentioned earlier, folks will often say, we're already doing it, but in fact, they may not be. We often have organizations that see a culture of safety as just one more new thing, trying to make it a new priority that's time limited at the expense of understanding that it really is our purpose. And we often hear that the true costs of a culture of safety are not well understood. And many of these issues around culture are squishy things. And people are concerned about not understanding them and concerned about whether or not they're actually costly to fix. We also have a workforce that, in fact, is not particularly healthy. We have so many of the conditions that I mentioned earlier with burnout, turnover, and depression. We also have physical and emotional health issues of our workforce. And all of this work to improve wellness of the workforce is critical because the pernicious and underlying cultures of fear and toxicity and disrespect that continue to expand the unhealthiness of our workforce exponentially increase the challenges of addressing this problem. Other critical factors include that for far too long, we've actually accepted that harm is a collateral damage of providing care and it's acceptable. We have organizations where leaders and governance bodies may lack accountability and where safety may not even be on a board agenda, or if it is, it may not be addressed in a meaningful manner. Healthcare still, in many factions, as you know, also operates under the impression that authority gradients are acceptable. And in many cases, and I know you've experienced this in some capacity, if we do address issues related to culture, it's often with a Band-Aid approach. We might apply a program, like a fatigue management program that's bolted on, so we can say that we did something, and we can conduct an in-service and tell people to feel better. Another reason why cultures of safety are hard to create and sustain is that we not only have some of the highest levels of turnover of healthcare professionals, as I've talked about, but we have the same thing happening at the leadership level, where an average CEO turnover occurs between every 3 to 4 years. And that really stifles the ability to have this continuous and compelling commitment to habitual excellence. And as I've also mentioned, the ways that we learn in healthcare is often from things that go wrong, instead of looking at things that go right and spending time examining that to ensure that we can create cultures that are safe. So let's move on to the critical success factors for a culture of safety. Building and sustaining cultures of safety, as I've noted and as you know, are hard work. The National Patient Safety Foundation and the American College of Healthcare Executives have actually been collaborating on the development of a safety culture playbook for CEOs to ensure that they understand and are able to impact the critical success factors that you see on this slide. And they include a rubric that begins with a compelling vision of a culture of safety and a full commitment to zero harm to patients in our workforce. It includes focus on respect and trust, just cultures, setting and holding all individuals, regardless of title, fully accountable for their individual and team behaviors. It also emphasizes leadership development in cultures of safety and the full engagement of board boards, and in the absence of boards, and this may be the case where some of you work, those who are ultimately accountable for managing and leading the organization. We do expect this work with very practical recommendations and tools to be available over the next few months on our website. And last week, during the annual Patient Safety Awareness Week that NPSF founded, we issued a call to action to address safety as a public health issue in order to build and execute concrete recommendations from our Free from Harm report, and to continue to ensure that cultures of safety are considered essential and that they are non-negotiable. This call to action can be found on our website. So let's get now to the final point that we're talking about today in terms of connecting the dots, and that's the relationship between cultures of safety and compassion. You have likely seen this slide before, particularly if you are a fan of all of the wonderful work of Dr. Lown and the Schwartz Center. And as noted in one of their publications, our healthcare professionals have to be able to adjust their responses to the needs of patients, along with the expertise and professionalism to respond effectively and appropriately. At the same time, those in healthcare must also be aware of how our reactions affect interactions with the patient and decisions about care. And we must use self-awareness to manage our emotions in order to act in the patient's best interest. There was a recent publication just a few weeks ago in Stat News titled, "Do Doctors' Other Motivations, like the Need for Sleep, Affect Healthcare?" And this was presented by Dr. Karen from the Harvard School of Public Health, who reminds us that it's really important to understand not only the extrinsic motivational factors, but the intrinsic motivational factors and circumstances that can interfere with our ability to provide the best care possible. He suggests that we remain grounded in performing constant self-checks and to cultivate habits of self-awareness to determine where we're at in any given moment as a type of forcing function, and in order to recenter our focus on the patient and his or her needs. I try to do this once a week when I take a few minutes and reflect upon how it's gone. I try not to do it on Friday because sometimes it's a bit more of a challenge, but I ask myself, what have I done this week that has really led me to become a culture carrier, and what have I done that has caused me to be a culture barrier? We can take the same framework that we shared earlier and apply the systems approach to change to compassion. If we think about compassion 1 and compassion 2, and I'll just briefly overview this, and from a definition standpoint, if we think about the meaning of compassion, there are so many that still look at it as an act, as something that's optional, as something that we do when something obviously goes wrong. And in the Compassion 2 framework, compassion is our core value. In so much of healthcare at present, compassion is often seen as something that I have to do, whereas in the Safety 2 framework, it is really the rule. It's constant and it's habitual. As a principle, compassion in the Compassion 1 context may be fleeting, where in the Compassion 2 context, compassion is our purpose. It's a necessity, as noted by the Dalai Lama, and as noted by all of you. It's embedded into our core, and it's essential in order to thrive. And when things go wrong in the Compassion 1 construct, we really tend to, at times, take measures that try to explain things away, whereas in the Compassion 2 construct, when things go wrong, we know that compassion is our purpose, but we also know that it's something that we do all the time, when things go wrong, when things go well, every day that we come to work. And we strive to understand how and why it works so we can minimize the incidence of harm, which is really so critical when we look at the value of the Compassion in Action webinars and all of the work of the Schwartz Center. In Compassion 2, our attitude to the human factor is that we can patch things up by adding a program. We often go into a doing mode versus a being mode. With respect to performance variability in a Compassion 1 framework, we tend to use a one-size-fits-all approach to providing compassionate care to patients, families, and the workforce. And it's not necessarily helpful, and in many ways it can be harmful. We see countless attempts to standardize the recipes for what to say and do for compassion. And we all know, and as Don Berwick says, when he discusses how to shift power back to the patients, that we need to take the N=1 approach. And this means that we strive for habitual excellence in compassionate and connected care over time, in meaningful approaches that are customized and situationally appropriate and adaptable for the patient and the workforce. This is an action hierarchy that is actually used in many safety industries, and the hierarchy itself is used to create frameworks for how we address something that may go wrong. So many times in healthcare, if there is an adverse event, we conduct what's called a root cause analysis and develop an action plan to be able to prevent something from happening again and to understand why it happened. The concept of this action hierarchy is actually simple. When we use weaker actions to address adverse events and challenges, which you see on the right side of this hierarchy, and this would include compassion, we often find ourselves working harder and believing that we're making change, when in fact we're doing a lot of doing, or there may be no time or time-limited improvements in our attempts to address problems. On the right side of this matrix, we might tell people to feel better, or say respect people, or only think that we should again act around what many people think are the obvious moments when they believe suffering must be occurring, when there's obvious physical pain or death. The right side, the weaker actions, are often, again, what we do, but they do not result in strong and sustainable change and progress towards cultures of safety. The left side, where actions are stronger, are markedly impactful in ensuring that we're able to understand why things go wrong or why things go well, and that we are continuing to sustain progress. So designing solutions and core systems around things that go wrong in the absence of learning from and applying what goes right in many ways can carry our journey to safe and compassionate care even further. And this is why you may want to take a look at the root cause analysis and action framework on our website and think about compassion as a hierarchy. And I know, again, that many of you are championing this and are leaders in your organization on this front. We're getting close to the end of our time today, but I wanted to comment on a couple of things. One of our Lucian Leap members, Dr. Amy Edmondson, who's a Novartis Professor of Leadership and Management and Senior Associate Dean for Culture and Community at the Harvard Business School, was recently interviewed in an Agency for Healthcare Quality and Research and Quality publication. And she states that she recalls a time when she used to think that people had this mental model in their head that as long as they did their jobs and went to work, that we would be taking care of patients and customers. However, she had a dawning, a noting of how profoundly interdependent people are in accomplishing nearly any significant goal. And I'd like to tie again in your minds this interdependency between safety, culture, and compassion as a necessity. Advancing cultures of safety and compassion are things that many of you are working on as part of your day-to-day work. And again, I'd like to just reinforce some examples of things that must happen. The leadership commitment, education awareness, and the full accountability for zero harm to patients in the workforce. How about interviewing and hiring and promoting for safety and compassion? In so many of these events, safety and compassion discussions never come up. We also are looking at ways to continuously drive organizational and individual learning, and many of you are leading programs on that front. And much of this work, as we know, has to become much more interprofessional with patients and family members at the heart of the team. Supporting the healthcare workforce is vital. We know that we cannot provide compassionate care if we do not have a healthy workforce and if morale is not in place, and if the team is not working together and is not well educated. We need to be able to focus on the workforce so they can bring out their best as healers and as compassionate and connected caregivers. There is a series of the 3R questions that were developed by Mr. Paul O'Neill, who's the former chair and CEO of Alcoa, and who used to serve on our Lucian Leap Institute. And he used to say that every employee of his organization at Alcoa should be able to answer affirmatively to 3 key questions every day when they come to work. Do I feel respected by everyone in my organization? Am I recognized for what I do and the contributions that I make? And do I have the resources that I need? The Kaiser system has actually added in a 4th question and created a People Pulse Index that is able to predict whether certain areas, the microsystems or the units, will actually have more harm and error that is occurring as a result of the 4th question that they add. Is there a response? Does the organization respond to issues before they become problems? Accountability for behaviors is very well exemplified, particularly in the work down at Vanderbilt with Dr. Jerry Hickson, who's created a professional accountability pyramid for professional behaviors and for addressing unprofessional and disruptive employees. Attention to physical and emotional harm and ongoing education awareness, and many of the programs that you see here, including the programs and the work of the Schwartz Center, are notable and are helping our healthcare workforce be able to build resiliency where it's been lost. I'd also like to just bring up a couple of more examples. How do we make this crucial progress to transparent and non-punitive approaches to reporting and learning from adverse events, close calls, and unsafe conditions? Well, again, this is a leadership issue, and for those of you who have not yet seen it, the Joint Commission actually issued a Sentinel Event Alert 2 weeks ago on the essential role of leadership in developing a culture of safety. And they encouraged several recommendations, including reporting systems which are accessible to everyone in the organization. We also need to focus on understanding and addressing, as you well know, that the long-term impact of emotional harm is very real. It is not just a time-limited event. And we're seeing examples such as at Cedars-Sinai, where cumulative stress debriefings are held with peers because they recognize that stress and suffering of their workforce is not necessarily tied to a single event. We've got recognition programs, the programs that are sponsored by the Schwartz Center, where they recognize compassionate caregivers, and also by the DAISY Foundation, with whom the National Patient Safety Foundation has recently partnered. We're in our 3rd year of providing the NPSF DAISY Award for extraordinary care in nursing. And as you know, the foundation of this award is all around compassionate care. Closing down here, a few more words. And these are words that Ken Schwartz identified during his illness. They're tenets that he envisioned would become our norm and not the exception of care. One is staying in the moment. And we know that stories are an important channel for doing so. We're often reminded in all of our meetings that we have here at NPSF that data are stories without tears. And alone, they're insufficient to activate change. Stories of the human side of our patient and family workforce safety, culture, and compassionate needs that we have for education. And so in times when people are not actually to be in the moment, to see things and experience things, if their leaders or executives are not working that shift, or if they're working in departments that don't interface with patient care, we have the opportunity to bring stories that bring constitutionally vital information and energy to activate and sustain cultures of safety. Ken Schwartz also talked about the smallest acts of kindness, and the smallest but most meaningful act of kindness that I experienced during my recent emergency department visit was from a high school student, a volunteer, who came into work after about 7 hours. She saw that I was shivering. I wasn't even looking at her, but she came over and asked me if she could bring a warm blanket. And this, to me, was the most meaningful portion of my 9-hour stay. And in return, we talked. And I learned that she was so excited to be working there that she saw herself as much more of a blanket hander-outer person, and I encouraged her to maintain that thinking and thanked her for what she did, especially when she saw and encountered all of the difficult situations in the emergency department where she was volunteering. And finally, I'd like to move on to our next slide with the words of Ken, which are around making the unbearable bearable. These are probably the 4 words that mean the most to me. They stick with me every day. It'll be 2 years ago next week that I lost a beautiful, vivacious, and healthy 25-year-old extended family member who died after a cadre of outstanding members of care teams across 3 facilities fought to save her over an entire week from the sepsis that had invaded her life for no obvious reason. Every one of the countless healthcare professionals who touched her life and the lives of our family that week had more than ample reason for this one patient alone to have exhausted their compassion. I knew they were facing their own pain, their anguish, their sense of futility, and they were suffering, and many of them were the exact age as my relative. They were peers who were trying to save the life of someone with the most incredible care possible, but never gave up giving it at all. And I know, again, that they were suffering because we talked about it. But they didn't exhaust the care and the compassion that we needed when it most mattered. And they made that week and the last 24 hours of my relative's unbearable situation as bearable and beautiful as it possibly could have been. And I'm grateful to say that it was in an organization that ensures access to Schwartz Center rounds and resources. They were operating in cultures where safety and care excellence was remarkable, and they connected as a team to connect our family to incredible connected care. On the final slide here, I'd just like to thank you and extend a note of gratitude for all that you do. You'll actually see an example of a pen that was sent to our office by an organization that likes people to buy tchotchkes for events. And you'll notice that the name on the pen, and this is not what we ordered, was spelled and interpreted incorrectly as the National Patients Safety Foundation. And while patience is a virtue, it isn't a virtue for patients and families and our colleagues who are suffering and for whom cultures of safety and cultures of connected and compassionate care every day should not be an option. I'm grateful to each of you who have joined us today and hope that you've taken something away from this discussion, and I'll turn this over for questions. Thank you.
Thank you so much, Patricia. That was moving and incredibly helpful and insightful. I really appreciated the Safety 1, Safety 2, Compassion 1, Compassion 2 framework. I think it's a really useful way of rethinking our concepts and the way we approach both compassion and patient safety. I don't know if we have any questions. Andrea will perhaps pipe in. But, you know, when you described that story at the beginning of your own experience in the emergency room, it just feels so overwhelming and daunting. You're a very expert observer of really flaws in the environment, the contextual elements that make a situation safe or not. And yet I so relate to the people who are running around, you know, in that emergency room while you're sitting there on a gurney, you know. And I think that the question is, facing these kinds of environmental resource constraints, all of the things that we deal with on an everyday basis, how can you help us think about some small steps that individuals can take to really sustain compassion and safety and care?
Thank you, Dr. Lown. That's a really important question, and it's one that I mulled over heavily in those 9 hours. I was in a teaching hospital, and I was surrounded by residents, first year, third year, all kinds of teachers. And I also was surrounded by nursing students and others. And I want to go back to the importance of creating the purpose of compassionate care as part of how we educate, and how we educate in what is increasingly interprofessional teams. And I think these are lots of areas where our organizations can really build stronger frameworks. We're starting to see this more with the American College of Graduate Medical Education, and also with the colleges of nursing who are focused on improving quality of compassionate care and understanding in their organizations. But fundamentally, I think, again, going back to this issue of cultures of safety, you know, I asked myself as I was sitting there, how do these people think about cultures of safety? There were many things that I could share with you that would make me wonder, what this particular organization was doing to provide care. Being able to recognize and calibrate your own capabilities, that self-awareness is really important, and being able to build systems where you can count on individuals to provide you with support or to give you a break in situations that are just nonstop is so absolutely vital. And I think the other important point around that is that we have wonderful opportunities here for simulation, not simulation of high technology, high fidelity simulation, but simulation of experiences. And being able to stop folks who are actually centered in doing that care and have them pause and reflect upon what they can be doing differently, to look me in the eye, to ask me what my personal goals were, some of the simple things that can create that compassion, to be able to say this elderly spouse needs a chair, such fundamental things, Beth.
Yeah, those small acts of kindness that Ken talked about. Well, I think we have a lot of questions from the audience and 5 minutes left. So let me ask Andrea to jump in here and pose some of those questions from our audience.
Absolutely. Thank you, Beth. We do have a number of questions, but it looks like we have time for about one or two. So we will do our best to answer those. Our first question here, building on your CDC slide, is there any utility from the phrase cultures of compassionate safety?
On this slide, building on the CDC slide, Andrea, can you just clarify for me again what that refers to?
Is there any utility from the phrase cultures of compassionate safety?
Actually, I think there can be. I think that's really important, and it's an interesting question. I fundamentally believe that cultures of safety can and should be compassionate, and I also believe that cultures of compassion should be safe. I see them as almost co-conditional, but in order to be able to help people get it, and we look at safety very often these days as physical safety. Let's reduce, preventable medical error, preventable infections, and other things. And so I think the compassion and the human side of care can get lost as we layer on a lot of these initiatives around reducing infections and other types of complications that typically occur. It's so very easy, and people tell us all the time that they lose sense of the patient in the bed for all that they have to do. And so I think there's actually a nice way to frame that word to build safety into the culture of compassion.
Fantastic. Thank you very much, Patricia. Looking into our last question for today's session, are there any studies on the topic of comparison between patient satisfaction related to compassion and patient safety, or a culture of safety for that matter?
There are numerous studies that relate cultures of safety to patient outcomes and also to the health and well-being of the workforce. And I can make some of those references available for individuals who may want additional resources. Be happy to hand those along, but indeed there's more and more coming all the time as we recognize that our workforce has so many needs that need to be addressed in order for them to be able to provide their best care possible.
Fantastic. Thank you very much. That wraps up our Q&A session for today. Beth, do you have any final thoughts to share with our participants?
Well, I just would really like to thank you, Patricia, and everybody for joining us. And I think it would be wonderful if you would like to supply some resources or reference lists. We'll post them on our website when we post the other handout and recording.
Thank you, Dr. Lown, and I'd be happy to take any questions that have not been addressed as we've spoken here today, if you're interested in posting them or sending them along to the participants.
Terrific. Thanks so much. Andrea?
Fantastic. I would again like to thank Patricia McGaffigan for sharing her insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We hope you enjoyed the second in a series of webinars focused on organizational cultures of compassion. These topics and more will be covered at our inaugural Compassion in Action Healthcare Conference to be held June 25th through the 27th, 2017, here in Boston. To register or learn more about the conference, please visit compassioninactionconference.org. We also hope that you will join us for upcoming programs in the Compassion in Action webinar series, including Compassion Integration, Connecting Hearts and Minds with Action, with Becca Hawkins and Mark Rosenberg on May 9th, 2017. Please visit our website to see our upcoming programming and learn more about the Schwartz Center for Compassionate Healthcare and our membership program. We know you are busy, but we would very much appreciate you taking a moment to complete the electronic survey upon exiting today's program, as we value your input. Thank you, and have a great day.